Good morning. So for our teaching rounds today, I've put together this explainer to walk through my induction and maintenance plans for the 2 IBD patients we currently have on our service. My goal here is to really defend my clinical reasoning as we match specific drugs to exact disease severities. Taking it all the way from basic topical therapies right up to cyclosporine rescue and surgical intervention.
Looking at the agenda, we'll start with the 2 IBD patients, move into the workup before you treat, then tackle the ulcerative colitis ladder, followed by the Crohn's disease ladder, and finally surveillance and our final plans.
All right, Section 1, the 2 IBD patients.
So, we have 2 recently diagnosed, completely treatment-naive patients on the list. First up, there's a 26-year-old woman presenting with left-sided ulcerative colitis. She's currently having 6 to 8 bloody stools a day, which puts her squarely in that moderately to severely active category. Then we have a 23-year-old man with ileocolonic Crohn's disease. Now, crucially here, his disease features perianal involvement, specifically a perineal fistula, and his overall disease is moderately active. It's really important to note their specific disease locations and severities because those exact details dictate literally everything we're going to do next. I haven't initiated therapy yet since I wanted to walk you through the justification for the precise pathways I'm recommending.
Moving on to Section 2, workup before you treat. Before we even think about writing a prescription, the evaluation has to be highly systematic. First up, the physical exam needs to deliberately check for extraintestinal manifestations. We're looking at the skin, eyes, and joints, and of course, evaluating liver panels for primary sclerosing cholangitis. Next, our lab panel includes a CBC with DIF, LFTs, ESR, CRP, and a fecal calprotectin. I'm also drawing iron studies, vitamin B12, folate, and vitamin D. We need those because, as you know, IBD severely malabsorbs nutrients, especially when there's terminal ileal disease. Then, we absolutely must exclude the mimics. That means ruling out ischemic colitis, intestinal lymphoma, colorectal cancer, irritable bowel syndrome, vasculitis, Behçet's disease, celiac disease, and SIBO. But crucially, the golden rule here is to rule out infections first. I am actively screening for tuberculosis, hepatitis B, cytomegalovirus, and ova and parasites before we start any immunosuppressants. Why? Because anti-TNF therapies will aggressively reactivate latent TB and viral hepatitis. The only real caveat to that rule is if we have an acutely toxic inpatient where emergent action is required.
Now, once that workup is secure, I like to establish 2 distinct phases of treatment: induce and then maintain. I often use a completely different drug for maintenance than I do for induction. That's because the drug's onset speed and its long-term toxicity profile rarely line up perfectly. The guiding principle here is that mucosal healing, not just symptom control, is the primary goal. A patient can feel entirely well on the outside, but have actively inflamed mucosa on the inside. And that ongoing microscopic inflammation, it relentlessly drives strictures, dysplasia, and eventually colorectal cancer. So to achieve true healing, I employ one of 2 strategies: either a step-up approach, where we start with the least toxic drugs and escalate only if the patient fails each rung, or a top-down approach, where we hit them with a strong biologic right out of the gate to halt aggressive penetrating disease.
Okay, let's jump into Section 3, the ulcerative colitis ladder.
For mild UC, I typically start with rectal mesalamine or a glucocorticoid suppository or enema. Topical therapy works beautifully here because ulcerative colitis practically always starts right at the rectum. Now, for mild to moderate disease, I step up to oral 5-ASA agents, things like sulfasalazine, mesalamine, ulcilazine, or belsalazide, and I choose the specific one based on exactly where the disease sits. We do have to watch out for complications like pancreatitis, abdominal pain, and diarrhea, plus remember to supplement folate if we're using sulfasalazine. Alternatively, we can use MMX budesonide. Its extensive first-pass metabolism is great for limiting those systemic steroid side effects. Then for moderate to severe disease, I escalate to oral prednisone at 40 to 60 milligrams, tapered over weeks, but that is strictly to induce remission. To maintain that remission, I use thiopurines like azathioprine or 6-mercaptopurine, dosed at 0.5 to 1 milligram per kilogram. And just to reiterate, azathioprine is strictly for maintenance. It's never a rescue drug because of its delayed onset. Finally, for severe refractory disease, I admit the patient for IV steroids, usually hydrocortisone 100 milligrams IV every 8 hours or methylprednisone 16 to 20 milligrams. If they fail that, I'll go to a cyclosporine infusion at 2 to 4 milligrams per kilogram for 7 days, but that's purely as a bridge to a thiopurine, never as a final destination.
Checking TPMT levels is absolutely not optional. It is quite literally how I prevent devastating toxicities. Thiopurine methyltransferase is the enzyme that metabolizes these maintenance drugs.
If a patient has low TPMT activity, those toxic metabolites accumulate rapidly, and that causes profound bone marrow suppression, lymphoma, pancreatitis, and severe hepatitis. So I always check this before the very first dose. Now, in selected non-responders, meaning those with appropriate TPMT levels but poor drug optimization, I will actually add allopurinol to carefully shunt the metabolism and boost the drug's activity.
When we have to escalate to biologics, I frequently reach for anti-TNF agents. The general efficacy order goes infliximab, golimumab, and then adalimumab. Interestingly, remission rates actually rise when azathioprine is combined with infliximab, compared to using either drug alone. But we have to respect the heavy risk profile here. Beyond reactivating TB and viral hepatitis, there is a serious risk of non-Hodgkin lymphoma. Specifically, there's a rare hepatosplenic T-cell lymphoma well described in young men on combination therapy. We also have to watch out for lupus-like reactions, paradoxical psoriasis, demyelinating disease, and congestive heart failure. Now, if an anti-TNF fails, that's when I utilize the newer classes: anti-integrins like vedolizumab, JAK inhibitors like tofacitinib, IL-12/23 agents, and S1P modulators.
All right, on to Section 4, the Crohn's disease ladder. The Crohn's disease ladder follows some very distinct sequencing rules. For mild disease, oral 5-ASA actually has a much smaller role here than it does in UC, and it's reserved strictly for colonic Crohn's. I'll also use loperamide or cholestyramine for bile acid diarrhea following ileal disease. For mild to moderate cases, I use enteric-coated butyrcyanide for targeted ileal release. But note, this is tapered over 3 months, not 3 weeks. For moderate to severe disease, I rely on prednisone 40 to 60 milligrams, thiopurines, following those exact same dosing and TPMT rules we just talked about, and I'll start introducing methotrexate at 15 to 25 milligrams intramuscularly, subcutaneously, or orally once weekly for maintenance. I also aggressively utilize biologics here, prioritizing infliximab and adalimumab ahead of certolizumab, often pairing them with a thiopurine. Then I'll look at vedolizumab, ustekinumab, resinculumab, or upadacitinib. For severe disease, we're talking IV steroids, anti-TNFs, or JAK inhibitors. Notice what's missing here? There's absolutely no cyclosporine rescue rung for Crohn's disease.
Now, there are 2 massive pitfalls we need to avoid in Crohn's management. First is the methotrexate timeline. Methotrexate takes a full 1 to 2 months to actually work for maintenance, so you simply cannot judge it as a failure at the 2-week mark. Second is recognizing when to use our top-down strategy. If a patient presents with a perianal fistula, that specific clinical feature instantly moves anti-TNF therapy to the absolute first-line choice. Furthermore, because anti-TNFs neutralize cytokines, anti-integrins stop lymphocyte homing, IL-12/23s block T-cell differentiation, and JAKs block downstream intracellular signaling, they all act differently. Because of this, failing one mechanism absolutely does not predict failing the next.
Of course, if medical therapy fails, we consult surgery, but it means 2 very different things for these diseases. For UC, the indications include refractory symptoms, drug intolerance, cancer, perforation, toxic megacolon, or uncontrolled hemorrhage. The operation is usually a colectomy with an ileal pouch anal anastomosis, and that is completely curative because removing the colon removes the disease entirely. But when I consult surgery for Crohn's, my absolute priority is minimizing resection to avoid short bowel syndrome. Why? Because unlike UC, surgery here is never curative. We resect for refractory disease or strictures, and we use diverting ileostomies for severe perineal disease, but the Crohn's characteristically recurs right at the anastomosis.
Finally, let's wrap up with Section 5, surveillance and final plans.
This is the grim reality. Ongoing inflammation relentlessly drives up the risk of colorectal cancer over time. The risk sits at roughly 2% at the 10-year mark, climbs to 8% at 20 years, and reaches a staggering 18% at 30 years. Pancolonic Crohn's carries a very similar trajectory, but it introduces an additional risk of small bowel cancer. So what drives that risk even higher? Well, dysplasia is the single best marker, but we also worry significantly about primary sclerosing cholangitis, a positive family history, greater disease extent, and the presence of strictures and pseudopolyps on endoscopy.
So, 8 years is the magic number. That is exactly when surveillance colonoscopy with random biopsies begins after diagnosis, and then it's every 1 to 3 years based on their risk profile. Increasingly, though, the standard is shifting to chromoendoscopy. That's where dye is sprayed directly onto the mucosa to highlight subtle, flat dysplasia far better than a random biopsy can. And if I see a dysplasia-associated lesion or mass, a DOM, or high-grade dysplasia, the plan shifts instantly. It means colectomy. We refer for surgery, we do not just observe.
Bring this all together. Here are the orders I am placing for our 2 admissions today.
For our 26-year-old woman with moderately to severely active left-sided UC, I am inducing her with an oral 5-ASA plus a steroid taper. Then I plan to maintain her with either a thiopurine or an anti-TNF agent, but that's pending her TPMT and infection screening results later today. Now, for our 23-year-old man with moderately active ileocolonic Crohn's, his fistula dictates an immediate top-down strike, so I am ordering an anti-TNF biologic as absolute first-line therapy for both his induction and his maintenance. And for him, that 8-year cancer surveillance clock starts right now.
Ultimately, managing IBD on the wards forces us into a very delicate balancing act, and it asks a difficult question. How will you balance the absolute urgency of achieving deep mucosal healing against the very real long-term risks of profound immunosuppression? As we prepare to walk in and examine these patients, it leaves us to wonder, how quickly will the next generation of highly targeted microbiome therapies rewrite these treatment ladders entirely? Let's go see the patients.